Okay, guys. Um, Thank you so much for coming. My name is Carolyn. I'm a senior. I'm on WALK and Unity Council, and I'm one of the co-presenters today.
Hi guys, I'm Isabella. I'm also a senior. I'm one of the presidents of the African American Affinity Group, and I'm also one of your presenters today.
Hi guys, my name is Ella. I am also a senior. I'm the president of the Pre-Med Club, and I'm also a co-presenter today.
Okay, welcome everyone to the second webinar of the MD series. We're going to be hosting these webinars throughout the school year, so be sure to keep an eye out for the next one. Thank you all so much for coming today and for investing the time to learn more about medical discrimination in all of its forms. This webinar will focus specifically on gynecology, pregnancy, and postpartum care. We'll be using the term women most often in this presentation, but we still want to shed light on other female-bodied folk who might not identify as women. We will try our best to make sure that this is an inclusive presentation, but please let us know if we can do better.
To start off, we want to also add a disclaimer. We are not experts on this information, and this webinar consists solely of our own research. We are going to be talking about difficult and for some of us personal topics. We will specifically be talking about race-based sexual harassment, slavery and racism, birth trauma, and systematic health injustice. With this being said, please feel free to take a step away from the computer.
Always know that a recording will be sent out as soon as possible, so you will not miss out on this information. We will only be recording the information part of this webinar. For your convenience, we put the majority of the information we will share onto the slides, so you also have the option of reading the slides at your own pace. The recording and the link to these slides can be found on the Unity Council website. Just search Medical Discrimination Series in the navigation tool. To start us off today, let us establish what medical discrimination is. Medical discrimination is prejudice and discrimination in medicine and within the medical and healthcare systems. It is based upon perceived race, gender, religion, ethnicity, sexuality, and more. Medical discrimination can manifest itself in 4 different ways: through conceptual ideas of identity, discrimination that results in different medical treatment, the experience of identity that negatively impacts one's health, and institutional discrimination. This webinar will focus on medical discrimination in the context of gynecology, obstetrics, and postpartum care.
Gynecology is defined as the branch of physiology and medicine, which deals with the functions and diseases specific to female-bodied people, of whom may or may not identify as female. Gynecology studies anything regarding the female reproductive system.
It is vital to mention exactly how gynecology began. The Partus Sequitur Ventrem in 1662 in Virginia was the legal doctrine mandating children of enslaved women to inherit an enslaved status. This doctrine arose in response to the end of the transatlantic slave trade, in which enslaved Black women would be raped by slave masters to produce biracial children and increase the enslaved population.
A Black woman's worth was measured by how many children she bore. For those who were infertile, slave masters would seek doctors to fix the enslaved women. This was the start of gynecology, not women's health. Gynecology was not born out of concern for women's health, but instead was started to increase the slave population.
Often referred to as the father of modern gynecology, Dr. James Marion Sims conducted numerous studies on enslaved Black women without their consent and anesthesia. This consent was only required by the slave owner, and anesthesia was willingly not given because doctors deemed Black women biologically inferior to white women and to have a higher tolerance for pain. It is important to note one young woman, Anarcha, who centered much of Sims' research. She was operated on by him 30 times without anesthesia. Only after 4 years of experimentation did Sims begin operating on white women with anesthesia. In 1856, Sims founded the first women's-only hospital, but only accepted white women. These white women were afforded privacy, sterile environments, and anesthesia. He gave the most anesthesia to the wealthiest white women who he believed to be the most susceptible to pain. Physicians like Sims were dependent on slavery, both for economic security and for the enslaved clinical material that fed American medical research and medical training.
In the 1900s, gynecological practice became more and more common. In 1916, Margaret Sanger opened the first birth control clinic in the US on the basis that women should be able to decide when they want children, and that birth control should be accessible to prevent back alleyway abortions. Sanger's feminist efforts only included white women due to the fact that she believed in eugenics, exclusionary immigration policy, and supported the KKK. This is one of the many examples of white, cisgender feminist efforts that exclude women of color and non-female identifying people in gynecological and obstetric practices.
In 1950, contraceptive trials in Puerto Rico is another example of medical discrimination in gynecology. This was the first large-scale human trial of a birth control pill. Prior to these human trials, the pill had been tested on animals in a few women in which side effects ranged from depression to death, which should have warranted the discontinuation of the trial. Instead, 1,500 Puerto Rico women, many of whom lived in poverty and who had multiple children, were enrolled in the trial. They were not informed that the drug was in a clinical trial, thinking that the pills was safe for use. In the study, 26 women developed life-threatening blood clots and 6 women died. There are no investigations into their death.
In 1951, Henrietta Lacks, a Black woman and mother of 4, went to Johns Hopkins to be treated for cervical cancer. In one of her biopsies, her cells were unknowingly taken from her and were studied as the HeLa cell line. Miss Lacks died after the biopsy, but her cell line made history and contributed to many medical breakthroughs, from the research on the effects of zero gravity in outer space, the development of the polio vaccine, to the study of leukemia, the AIDS virus, and cancer worldwide. Her family did not find out that Johns Hopkins used her cell line until 1975, and her family still has not received any of the profits, even though the researchers disregarded and profited off of her.
Due to the passage of the Family Planning Services and Population Research Act of 1970, sterilizations were subsidized for those who received their health care from the Indian Health Service and for Medicaid patients. Black, Latina, and Asian women were also targets of coercive sterilization in these years. But most affected were Indigenous women who lived on reservations, and they were forcibly sterilized. From the 1960s to the 1970s, roughly 70,000 Indigenous women were sterilized without their consent, compared to the sterilization for white women, which was 15%. These coercive sterilization procedures only stopped after protests and pressure from Indigenous activists.
Forced sterilization on all women was only deemed illegal in 1981. This practice was most commonly used on Black and Indigenous women. While technically illegal now, from 2006 to 2010, more than 148 female inmates in Chowchilla, California, were given tubal ligation, a sterilization procedure, in their prison without record of consent. Due to the overrepresentation of BIPOC in the criminal justice system, minority women were most affected by the sterilization procedure. On September 14th, 2020, Dawn Wooten, a nurse working at Georgia ICE Detention Center, blew the whistle on the conditions within the privately operated Irwin County facility. Currently, many of the immigrants forcibly detained in the center are experiencing inhumane living conditions, a lack of protections against COVID-19, and extreme medical neglect. Medical staff, as well as detained women, allege that an alarmingly high rate of hysterectomies, a surgery in which part or all of the uterus is removed, are being performed by a privately contracted doctor. Many of these women are not proficient in English and do not understand the reasoning and details of the procedure.
All of these events have only reinforced medical discrimination within gynecology. Today, Black, Latina, and Asian women have less timely follow-ups from their physicians after an abnormal finding in a mammogram. Black women overall are less likely than white women to undergo biopsy. Secondly, Black females are less likely overall to have breast cancer than white females, but are 40% more likely to die from the disease due to misdiagnosis or no diagnosis altogether. And lastly, a Black female is 71% more likely to die from cervical cancer than a white female. These are only a few statistics, but in all, gynecology today, as it did from its founding, still favors white, wealthy, cisgender women over minorities.
The period tax is another form of medical discrimination that persists today. The average box of tampons is $6, and the average cost of pads or panty liners is $5. 30 states view period products as luxury goods and impose a sales tax, aka the period tax. Contrastingly, groceries and medications are tax exempt, as they are considered to be non-negotiable necessities. The period tax is an example of invalidating the experiences of women and other female-bodied people as a whole within a patriarchal society. Men's items such as Viagra, Rogaine, and condoms are exempt from the sales tax.
Due to the period tax and the price of period products on a whole, period poverty is the reality of millions of low-income minority communities and homeless women and other female-bodied people. In a given day, there are roughly 80 billion people menstruating, and 500 billion of those 800 billion lack adequate resources to manage their periods. On average, 1 in 4 students miss school due to the lack of access to menstrual products.
During the pandemic, period poverty has grown exponentially. Only 1 in 3 menstruating people struggle to buy period products. And among the homeless population, many have reported increased prevalence of infection caused from misuse of tampons and pads, or the use of a substitute, such as paper towels or newspaper. And among the prison system, incarcerated individuals often beg or bargain with staff for basic hygiene needs.
Medical discrimination within gynecological practice and healthcare in general has deeply influenced discriminatory and unequal care in obstetrics. Obstetrics is defined as the branch of medical science that deals with pregnancy and childbirth.
In our last webinar, we discussed the social determinants of health, in which we concluded that BIPOC are continuously and systematically disadvantaged when it comes to health status. This picture demonstrates the multifaceted nature of health, which is influenced by economic stability, social context, environment, access to healthcare, and resources like education. BIPOC women, especially Black women, are affected by systemic inequalities and discrimination that leads to chronic stress, which has been shown to reduce the healing capacity of a person's body, which includes general reproductive health, fertility, pregnancy, and postpartum care. This concept illuminates the embodied psychological effects of living in a racist society, also known as racial weathering.
The concept of weathering was first hypothesized in 1992 by Princeton scholar Arlene Geronimus. She worked closely with pregnant teenagers in New Jersey and concluded that Black women's health deteriorated in early childhood as a result of the cumulative exposure to socioeconomic disadvantages and racism and sexism. BIPOC stress and minority stress are similar concepts, but weathering often centers Black women.
The effects of cumulative racism and weathering was investigated in a coronary artery risk in young adult study from the 1980s to the 2010s. Among the 2,700 middle-aged Black and white participants, the study concluded that Black participants aged 6.1 years faster than white participants. It also confirmed that a difference in psychological and socioeconomic experiences take a larger toll in the psychological health in Black individuals than in white individuals.
Health inequalities due to weathering can also include increased risk for diabetes, heart disease, mental illness, cancer, stroke, obesity, and more. Weathering solidified the idea that this is the embodied effects of living as a BIPOC in a racist society that produces health inequalities. Weathering and its preceding health inequalities make many BIPOC pregnancies high risk.
These health inequalities and chronic illnesses in turn increase the risk for high-risk pregnancy. For those wondering, a high-risk pregnancy is any pregnancy that requires special monitoring and care, often due to an underlying health problem before pregnancy or a health disorder that arises during pregnancy or during delivery. A few factors that would be classified as high-risk pregnancy include high BP during pregnancy, diabetes during pregnancy, being HIV positive, obesity, cesareans from past pregnancies or current delivery, and being pregnant with twins and higher order multiples.
Due to the racial weathering and the health inequalities among BIPOC women, many minority women and other female-bodied people are diagnosed with a higher risk pregnancy. However, as explained in the last webinar, when BIPOC access healthcare, their treatment is often unequal due to prior provider implicit bias. This is most prevalent in today's Black maternal mortality pandemic, in which the US has the highest maternal mortality rate in the developed world. For example, Black women in the US are 243% more likely to die from pregnancy or childbirth-related causes. Black mothers die at 5 times the rate of white mothers, one of the widest of all racial disparities in women's health, and 12 times the rate of white mothers in the state of New York during pregnancy or childbirth due to racism in the healthcare system. Also, the risk of death for Black babies is double that of white, Asian, and Hispanic babies.
Gathered from the CDC, this graph illuminates the pregnancy-related deaths in the United States from 2007 to 2016. As you can see, pregnant Black and Indigenous people are among the highest death rates. Interestingly, this graph showcases what is called the Hispanic paradox, the fact that Latinx people are systematically disadvantaged in the US but have a lower maternal mortality rate. More studies are being conducted on this topic. And today in 2020, the pregnancy-related deaths among the Black community specifically are hypothesized to be significantly higher than shown in this graph.
Tennis star Serena Williams publicly shared her experience of race-based birth trauma, in which, one day, delivering her baby via emergency C-section, she lost her breath and recognized the warning signs of a serious condition. Serena walked out of her hospital room and approached a nurse. Gasping out her words, she shared that she feared she had a blood clot and needed a CT scan and an IV of Herapin, a blood thinner. The nurse suggested that Williams's pain meds were making her confused. Serena insisted that something was wrong, so they conducted an ultrasound on her legs to address swelling. When that turned up nothing, she was finally sent for a lung CT, which found several blood clots. And just as Serena had suggested, heparin fixed the issue. William's story illuminates the fact that even a celebrity, an extremely wealthy Black woman, is likely to experience provider implicit bias, and in William's case, race-based birth trauma for no other reason besides the fact that she is Black.
Overall, discrimination and the stigmas associated with postpartum care significantly affects all female-bodied people, especially in the US. Still, this discrimination is exacerbated among the BIPOC community.
This is shown in America's relationship with maternity leave. Maternity leave in the US is looked down upon in our patriarchal society. Lack of maternity leave, however, disproportionately influences low-paid and part-time workers the most, simply because they're unable to take time off and still have enough money for basic necessities. The lack of job flexibility pushes female-bodied people to jump back into the workforce after delivery.
Within postpartum care, breastfeeding and lactation racist roots in the US still affect specifically Black women today. In the 18th century, breastfeeding was perceived as demeaning and uncultured, so white mothers would refrain from breastfeeding to maintain stature. However, children of enslaved people grew healthy from breastfeeding, while white babies were dying. The solution? Enslavers extracted the breast milk from enslaved women's bodies. This forced enslaved Black women to dedicate the majority of their milk to white children. To substitute breast milk, they would feed Black children substitutes such as cow milk, but as a result, the death of enslaved babies began to rise.
Today, the racist legacy of breastfeeding resulted in a lack of Black representation in lactation and motherhood spaces, as well as academic cultural barriers. Additionally, the CDC reports that Black women have some of the lowest breastfeeding initiation rates and the shortest breastfeeding durations across all race groups.
Among all female-bodied people, postpartum depression holds a significant stigma in a patriarchal society. This stigma is extremely prevalent in minority communities where mental health care is not accepted, and among the lower income population, not sustainable. Additionally, provider implicit bias is prevalent in the lower initiation rates by physicians for Black and Latino women to seek rehabilitation for postpartum depression. The same study showed that only 23% of low-income women, especially those from a racial ethnic minority group, were diagnosed with postpartum depression for their healthcare provider, and that Black and Latino women were less likely than white women to accept and sustain mental health care after delivery. In this case, white women were twice as likely. These differences in initiation and maintaining care imply that a disproportionate number of Black women and Latina women with postpartum depression do not receive adequate care. This only illuminates the racial and ethnic disparities related to outreach, detection, service provision, quality, and process of postpartum mental health care. We do want to highlight that this study only focused on Black, Latina, and white women. However, it should be explained that BIPOC experience lower rates of mental health outreach and care. To discuss more about this, stay tuned because we will have a whole webinar dedicated to discrimination within mental health care.
Unfortunately, non-cisgender female body people are often left out of the OBGYN conversation. Specifically among pregnant transgender men, a 2015 study revealed that pregnant men experience significant amounts of gender dysphoria, discrimination among providers, assault, and overall loneliness during pregnancy. Speaking specifically about gender dysphoria among transgender men and also pregnant non-binary folk, delivery and breastfeeding, sometimes referred to as chest feeding, exacerbates this dysphoria. 33 to 36% of pregnant men requested cesarean delivery to disassociate from natal female genitalia. Secondly, breast or chest feeding increases possibility for gender dysphoria. The choice to feed his or their infant varies among the person. Testosterone hormone therapy plays a significant role in transgender male pregnancies, so if you would like to know more about that, please let us know and we'd be happy to share more information with you. As we know, depression and suicide rates among transgender individuals is significantly high already. This highlights that depression during pregnancy and postpartum depression merits special attention among both transgender men and pregnant non-binary folk.
Especially for prospective healthcare providers, you can't just vow to not fall down this path. You have to actively be anti-racist and combat your implicit biases. You have to make active allyship a lifestyle and not just a reactive mindset. We have to identify, understand, and combat our implicit biases. Keep educating yourself on medical discrimination. Be involved in anti-racist patient advocacy programs. Promote increased cultural competency and diversity training programs for your medical professionals. Make active allyship a lifestyle and not just a reactive mindset. And finally, understand that medical practice and science has never been neutral. Science is an institution that has been carried normalized biases and discrimination from its founding.
So some specific actions that you can do for this specific webinar is to support Black-owned birth centers and doula practices. We have a few listed here. Make legislative efforts, specifically the Black Maternal Health Minibus Act of 2020 and repealing the tampon tax. Demand comprehensive, inclusive gynecological health education surrounding gender fluidity in obstetrics and gynecology, menstruation, and access to period products in schools, shelters, and prisons. And lastly, donate period products to local shelters and food pantries. Just know that this slide will be available to you after the webinar.
So some specific resources for minorities. Keep educating yourself on medical discrimination. One way you can do that is by keep attending our series. Engage in BIPOC-owned programs that specialize in minority patient care. Engage in programs that specialize in minority patient advocacy. If you request testing or medication and a doctor says no, ask them to document refusal in the chart. Ask your healthcare provider if they're aware of the discrimination in medicine and if they are actively anti-racist or other in their patient care and beyond. If there's any hesitation, find a new provider. If you feel that your healthcare provider is racist, file a formal complaint. Most healthcare organizations have a patient relations department that are equipped to address this type of concern. Write down questions ahead of time. It can be easy to forget what you want to ask. Ask your friends who they recommend. Go to a physician who has made your friend or family member feel heard and comfortable. Bring a support person. Bring someone you trust to be your note taker and to help you speak up when asking questions. And always get a second or third opinion when available and timely.
Feel free to contact us for any questions or comments. We breezed through a lot of information today, so if you want a little bit more information on a few of the topics, please feel free to reach out to us at any time. Again, thank you so much for coming, and we'll move on to questions now.